So, good afternoon and welcome to this webinar by EUROSPINE on the topic of scoliosis, which is taking place during the Scoliosis Awareness Month. Our agenda today will be 3 talks covering different topics around scoliosis, one on the conservative treatment options and the physical activities you may participate in even when you have scoliosis. Then we will hear a talk on the surgical treatment options, and in the end, a talk on the life you have after surgery and what long-term outcomes you may expect. So the learning objectives of this webinar is to understand in which sports and physical activities you can participate, even if you have scoliosis. You will learn about the different treatment options for scoliosis, including surgical and non-surgical options, and discover what you can expect in terms of recovery and long-term outcome after having a scoliosis surgery, and find out more what impact scoliosis surgery can have on your future activities and overall quality of life. It's important to know that this webinar provides you general information about scoliosis, but if you have individual questions, it's best to talk with your treating surgeon or spine specialist. Let me shortly introduce EUROSPINE. EUROSPINE is the Spine Society of Europe. It's a professional non-profit organization focused on the advancement of spine research and treatment. And it's your destination for everything all around spine. With that aim, EUROSPINE is also running Patient Line, which provides information for patients with spine condition explained in a clear, reliable, and trustworthy manner. It's available in several languages and can be found on the EUROSPINE homepage on eurospine.org, where you can navigate to patients, and you find a lot of information around different spine conditions, as well as you can navigate to different areas where you might experience pain. And all that is available in several languages, and there are more languages to come up as we are launching our new webpage. So let me introduce you to our speakers this afternoon. We have with us Nikos Karavidas from Athens in Greece. He is a physiotherapist and researcher focusing on scoliosis treatment, and he will give us the talk on non-surgical treatment options. Then we have with us Ahmet Alanay, who is a very experienced spine surgeon working in Istanbul, Turkey. And it's a great honor to have him with us this afternoon, as he's our current president of the European Spine Society. And last but not least, we have Javier Pisones with us, who is also an orthopedic spine surgeon and very dedicated researcher, and did a lot of research around long-term outcome after scoliosis treatment, and he's working in Madrid in Spain. And let me introduce also myself. I am Peter Felch. I'm an orthopedic surgeon working at the Medical University in Graz. And I have the honor as a current chair of the Patient Line Committee to moderate this webinar. I would like to invite you to submit questions throughout the question and answers tool throughout the webinar, and we will try to answer them in the end. And this webinar will be recorded and will be available online after the recording. So I'll start off with a short introduction on scoliosis. When we look at the healthy spine, the spine is composed of vertebra and discs, which lie between them and act as shock absorbers. We have 7 cervical vertebrae, 12 thoracic vertebrae, and the lumbar spine is composed of 5 vertebrae. Furthermore, we have strong ligaments and muscles who give the spine a strong structure, but also give it flexibility and allows movement. Within the spinal canal, we have the spinal cord, and then the nerves, which are running to the arms and legs. When you look at the spine from the front, it should be straight. When you look at it from the side, you have an S-shaped curve, which develops during childhood and adolescence. So scoliosis is a condition where the spine twists and curves to the side, and it appears as a C or S shape. A curve with an angle of more than 10 degrees has been defined as scoliosis. It's important to remember that scoliosis is always a 3-dimensional deformity, and it involves an abnormal curve of the spine to the side, as well as a rotation of the vertebra. Due to that rotation of the vertebra, ribs are shifted backwards on one side, which leads to a so-called rib hump, which is a very typical symptom of scoliosis. So that's also a way how scoliosis can be diagnosed and recognized early. There's the so-called Adams test, where patients are asked to bend forward, and then when you look at the back, you can easily recognize the rib hump or lumbar hump. That's a very sensitive test for scoliosis and should be used for screening. If there is any suspicion for a scoliosis, then your spine specialist will do radiographs of your spine to further classify the scoliosis and show you which treatment options are available for you. Other symptoms of scoliosis can be an asymmetry of the shoulders or the shoulder blade. The space between the arms and the body on one side can be increased. One hip may appear to be higher, and in some cases the head is not exactly centered over the pelvis, as well as the waist may be flattened on one side. There are different causes for scoliosis. One cause can be a congenital spinal abnormality, where abnormally formed vertebrae are already present at birth and can lead to a curve of the spine. Then there are several neurologic and neurologic disorders and muscular diseases which can lead to scoliosis, as well as some genetic conditions. But in most cases, a cause is not found, and in such case, the scoliosis is caused idiopathic when it occurs in otherwise healthy child or adolescents. It is very important to recognize scoliosis early, as scoliosis can occur and progress during childhood and adolescence. When it is recognized early, it can be treated successfully in several cases with a brace or conservative treatment. However, there are also some cases which will require surgery. It is important to remember that an early diagnosis gives the patients more treatment options, conservative as well as surgical options, and can lead to a better prognosis overall. So that's also why EUROSPINE is supporting the Scoliosis Awareness Month to raise the awareness around this condition. So I may hand off the talk to our next speaker, who is Nikos Karavidas from Athens in Greece, and he will give us some more information on the conservative treatment and scoliosis. Thanks, Nikos, for being with us this afternoon.
Hello, good afternoon. Thank you for the invitation to give this lecture today. I hope now you can see my screen. So my lecture will be about the impact of the diagnosis and ability to participate in physical activities. Some common questions from the patients or the families about scoliosis and activities and sports. Can a wrong posture cause scoliosis? Which sport can help me? Or is there any sport that is not allowed when you have scoliosis? Do hand dominant sports predispose for progression? Can Pilates or yoga treat my scoliosis? Can I practice sports where I wear my brace? Will I be able to do sports after scoliosis surgery? So we're going to address all these questions during this lecture, and also what are scoliosis-specific exercises and how they can help me. So scoliosis symptoms or concerns, we have the medical part, the medical issue, scoliosis progression in adolescents, further progression, adulthood pain and impaired breathing function. We have the cosmetic issue, poor self-image, low self-confidence, clothing problems, and avoidance of body exposure to the others. And the psychosocial part with reduced social activity, sometimes bullying at school, depression, personal relationship also can be affected. So all these can lead sometimes to poor quality of life. To treat scoliosis, we need an interdisciplinary approach with a therapeutic team consisted by orthopedic surgeon, orthotist, and physiotherapist. We have to be based on the evidence-based medicine, so we need the clinical experience, which means what the clinician knows, scientific evidence, what the literature says, and the patient preferences, what the patient wants. And we have non-operative and operative treatment. In conservative treatment, we have observation, scoliosis-specific exercises, and bracing. And in operative treatment, we have spinal fusion or other non-fusion techniques. The aims of non-operative treatment of adolescent idiopathic scoliosis are to have a 3D treatment of the deformity, stop progression or even partially correct sometimes, improve clinical appearance and aesthetics, train for activities of daily living, decrease pain, improve breathing function and quality of life. These are some guidelines from the Society of Scoliosis Orthopedic Rehabilitation Treatment, published in 2016 about scoliosis-specific exercises and bracing. So in general, when we have a mild scoliosis below 25 degrees with the patient still growing, we can apply scoliosis-specific exercises as an exclusive treatment. When the curve is getting bigger, overpassing 25 degrees, we have brace indication. And when we have brace treatment, also we combine brace and exercises to get the best results. Obviously, we can apply scoliosis-specific exercises also in adults. These are also some guidelines about scoliosis and sports activities. So to clarify, first of all, there is no sport that can be prescribed as treatment for idiopathic scoliosis. However, we encourage our patients to participate in sports for the general benefits, psychological, neuromotor, and general organic well-being benefits for them. It is recommended that also at school activities, we encourage the patients to do the whole program together with the classmates so that they don't feel restricted in some way. And also during brace treatment, they usually just remove the brace and they practice sports. Sometimes only contact sports can be problematic when the patient wears a brace. Now, let's have a quick look about what the International Scientific Society says about the scoliosis-specific exercises. In some of their statements in the past, they say that scoliosis-specific exercises can be the first step in scoliosis treatment with the aim to stop progression and avoid bracing, if possible. Scientific evidence that PSCC are superior to non-specific general or no exercises. So we have growing evidence with recent high-quality studies proving that PSCC can be effective in reducing the likelihood of progression. And when we have brace indication, of course, the best result can be achieved by a combination of brace and scoliosis-specific exercises. Many times when we have a mild scoliosis, the recommendation by the doctors is wait and see approach. So just come back after some months to have another reevaluation or doing general or no sports, general exercises. The good thing is that there is no fatigue, no cost for the patient, but it's not a real treatment and the result is unpredictable. So with scoliosis-specific exercises, we intervene with a try and see approach. We have an individualized program. So we reduce the potential for progression. This is a real treatment. And also we can predict the result because we use some specific evaluation tools that can predict what will happen on the next X-rays. Sometimes, of course, we can create a potential over-treatment because some cases might not progress even by doing nothing. Scoliosis-specific exercises are curve pattern exercises based on 3D autocorrection, patient education for activities of daily living, and stabilization of the corrected posture. And for idiopathic scoliosis, of course, we don't know the exact cause, but we know how scoliosis goes into progression. And I will very briefly explain this for you so to understand better what is the role of the scoliosis-specific exercises. For some unknown reason, we have a spinal curvature to be developed. So we have asymmetric loading, asymmetric growth, brow wedging, and so on. So there is a vicious cycle. And what we want to do is to reduce asymmetric loading by doing exercises or bracing. It's the same concept. So we provide a 3D correction and we reverse the asymmetric loading, the asymmetric growth, and the vertebral wedging. Scoliosis-specific exercises have some principles of correction. We have 3D auto correction, so self-elongation correction of the pelvis in 3 dimensions and curve pattern-based corrections in all planes. We have the corrective or rotational breathing to expand the collapsed areas and the rib cage. So we also do manual techniques to train the patient. And we have muscle activation in corrected position. So specific activation based on curve pattern and mobilizations. And after finishing the exercise, we need to maintain the correction and to implement it into the daily life. And this is a lifelong education for the patients. So during the exercises, we have to do a 3D correction of the scoliotic posture. And then we need to train the patient for activities of daily living. So how to stand, how to sleep, which side, what to avoid. And all this is curve pattern specific always. What we actually do with the exercises actively, it is exactly the same concept with the brace. But the brace works passively on the patient and can give a stable 3D correction. So we have 3-point systems for alignment in the frontal plane, a pair of forces for the transversal plane for regional derotation, and also we need to maintain a physiological alignment for the sagittal plane, normalizing kyphosis and lordosis. So on this slide, you can see the correction in the brace on the second X-ray, and also the improvement on the patient statics. Here you will see some results. For example, when we have a patient with a mild scoliosis, we can work only with exercises, and the aim is to stop progression and to avoid or delay bracing. Like in this case, that we got some reduction of the curve. Again, in this one, from 23 to 9 degrees, doing only exercises. In older patients, more mature patients, we can still work only with exercises with a concept of avoid bracing, improve body balance and aesthetics, and reduce potential for long-term progression. Like what you see in this example, we got a very nice correction of the curve. This was a patient at reserve 4, so at the end of growth, with a curve even more than 25 degrees, with exercises, we got a very nice result, improving both cob angle and body balance and symmetry of the patient. In adults, sometimes even with more severe scoliosis, we aim to improve aesthetics and pain, reduce potential for long-term progression, if possible, to avoid an operation for them, like what you see in these young adults. Of course, when we have brace indication during adolescence, we must combine brace and exercises, and many times we can get very nice improvement, radiological and clinical. Like in these patients, so when we add exercises to brace, we can enhance the result, even sometimes with less brace wearing time, which is very important for the patient, avoid an operation and improve aesthetics. Again, you can see another very nice correction in this double scoliosis from 30 and 36 degrees went down to 16 and 23, respectively, by combining brace and exercises. And even sometimes with more severe scoliosis, we can have, again, very good results by combining bracing and exercises. Again, another one from 48, we went down to 39, having also a very significant reduction of the hump of the patient and the body symmetry as well. And of course, sometimes we can also combine an operation with scoliosis-specific exercises, like in this case with selective thoracic fusion. So many times the surgeons, they try to save levels of fusion for the lumbar spine. And in these cases, we aim to stabilize the secondary curves and to improve body balance and aesthetics. Non-fusion techniques that you probably listen more information from the next speakers. Posterior dynamic distraction device or vertebral body tethering can be combined with exercises, and we aim to get further correction postoperatively, enhance growth modulation, and improve body balance and aesthetics. Or with a hybrid option, like in this example, that we had selective thoracic fusion and lumbar vertebral body tethering. We can also work with exercises after that. For the last part of my presentation, I would like to introduce to you, some of you, if you don't know, that there are many famous athletes suffering from scoliosis. So this means that scoliosis is not a restriction and should not be. Like Usain Bolt, Jessica Thompson, Alexandra Marinescu, and Natalie Coughlin at the highest level of their sports. Some people, they also think about Pilates, yoga, or other ways of exercising the body. So it doesn't mean that anyone that has scoliosis should do only scoliosis-specific exercises. They can also do other exercises a little bit cautiously. So you can also modify some Pilates or yoga poses for scoliosis. And to conclude, For someone that has scoliosis, they don't have to be afraid of that because it can be effectively treated either with non-operative treatment for mild and moderate curves or with operative treatment in more severe scoliosis. Of course, they are not restricted or disabled, and we encourage them to participate in sports and activities for their psychosocial benefits. Scoliosis actually is not always a good predictor of quality of life. It means that some people, they might have severe scoliosis but living a good quality of life. Some others have more moderate, but they can have problems. So the treatment decision should be based on individual criteria. Always the patient, they should seek for a specialist to take care of their conditions, and for sports or activities, they are allowed, and we encourage our patients to participate, but they are not a part of our treatment. Thank you for your attention.
Thank you very much, Nikos, for this talk. Very interesting information, and important to know that really activity and sports are very an important part of scoliosis treatment. And now I might hand over to Ahmed Alanay, who will give us some insights into the surgical treatment options.
Okay. Thank you, Peter. Thank you also for organizing this, I think, very important webinar. So I just would like to start, and hello, everyone. And I just would like to start saying that scoliosis actually is not a disease. It's actually a condition, and it can be seen with the prevalence of almost 3% among the adolescents. And majority of them are actually not really causing or needing any treatment, but only 20% of them may need some treatment, and very few of them may need surgery. So who needs surgery? Those patients who really have their curves exceeding over 45 degrees during growth, or at the adult deformity ages, deformities for thoracic curves over 50 degrees, or lumbar curves over 40 degrees, may need some surgery, as they may develop some problems or consequences which might really decrease their quality of life. So our surgical treatment methods today can be divided into 3 categories, actually. And fusion is the gold standard, and also we have now some non-fusion solutions and also some hybrid solutions, and I will just mention briefly about them. So why do we do fusion surgery? Or why do we need a surgical treatment? Actually, it is okay. So why surgery? Because we want to change the natural course of scoliosis and to stop the progression and prevent further curvature of the spine. Why is that? Because if we allow the curvature to progress, and if it exceeds certain threshold values or magnitudes, then it may really cause pain, some respiratory problems and heart problems, and very rarely nerve compression issues, really decreasing the quality of life. So in that case, we definitely need to treat those patients whose curves are progressing despite all the therapies, or somehow neglected and came with some big curves. Aims of the surgical treatment, on the other hand, first of all, is to provide a pain-free balanced spine. And of course, ensure optimal functional level, because the gold standard fusion may just stop the motion in between the vertebral bodies. So our philosophy to ensure the optimal functional level is always to fuse or to fix as short as possible. Then, of course, we aim to achieve the best cosmetic appearance and promote mental health and well-being by getting a good correction. And of course, finally, our main aim is to prevent future issues that could reduce quality of life. The gold standard surgical treatment is fusion, and it actually involves joining 2 or more vertebrae, of course, many vertebrae for the scoliosis surgery. And so we fix the vertebra together to correct the curve. And we fix the vertebra by using metal rods, screws, and then we need to put some bone grafts to stabilize the spine and to get the spine connected to each other. So again, the principle is always to fuse as short as possible. Of course, this depends on the curve character. What are the advantages of fusion surgery? Well, it's a gold standard since the century, I can say, with huge experience. And the results are more predictable. And it is usually a one-time goal surgery. And of course, it is the only option, especially for the curves, as can be seen here, like this 131 degree of neglected scoliosis, or the other one, 88 degrees of curves. And it's the only option. And if the curve reaches to this magnitude, then it really becomes a life-saving surgery. So this is a typical example for a fusion surgery. This 40-year-old female patient has a 62 degree of thoracic curve and 51 degree of lumbar curve. So we always try to aim to preserve the motion in the lumbar spine and not to go to deep to the lower lumbar spine. And then this patient was convenient for that. And so we did only a thoracic fusion for this patient, sparing the lumbar motion. So we get this good result with some residual curve, which will never progress in the adult life period of this patient. Also, you can see scoliosis is actually a 3D deformity. And if you look at the preoperative X-ray, the patient had a lordosis where she had to have kyphosis, and then this kyphosis was also restored by the surgery. And these are the clinical appearances, and we always evaluate our patients, as Nikos has mentioned, not only in terms of magnitude of the curve, but also in terms of the health-related quality of life, like function, pain, and perception of self-image and the mental health. And there is a significant improvement in this patient. But fusion may have some disadvantages. It may cause limitation in motion, as I have said it before, and may interfere with growth in patients, especially with growth potential. And it may cause some adjacent segment degeneration. That means, some disc diseases just next to the fused segments. Very rarely, lack of bone healing may cause some rod breakage, pain, and loss of correction, and may cause weakening of back muscles. But again, these are disadvantages. But if you compare with the advantages, actually fusion again is the standard procedure and is a life-saving procedure. But we surgeons have looked for different options, and one of them came almost 10 to 12 years ago, was the non-fusion scoliosis surgery, which is today named as vertebral body tethering. And as Nikos has shown, there are some asymmetric growths in the scoliosis that may affect or may cause the progression of scoliosis. So what we are doing here is we do a surgery from the front with a minimal invasive technique through the holes. And then we just insert our screws on the convex side and then connect those screws with a plastic cord. And we change the actually asymmetric growths just in the opposite direction. And we harness the growth and we change its route by decelerating the growth on the convex side and accelerating the growth on the concave side. So we can get some additional correction during the growth of the patient. This surgery has limited indications, and the patient should be skeletally immature with a curve between 30 to 65 degrees, thoracic and lumbar curve. And of course, there should be a trial of brace, and the patient should fail a brace treatment, reaching to these curves over 40 degrees. Advantages: it may preserve motion, and it's a growth sparing surgery. So actually, it's using growth to correct scoliosis. The scar is hidden underarm as it's on the lateral side and only 6 holes. And shorter hospitalization, and those patients may have a rapid recovery. But the disadvantages, on the other hand, we don't have long-term results, and it's a technique still in its infancy, although we have been doing this technique since more than 10 years, and may necessitate multiple surgeries, like due to the complications like overcorrection or the breakage of the plastic and conversion to fusion in those patients who failed for this surgery. This is a typical patient which is with a good indication, a growing patient with a significant growth potential. And for the 41 degree of magnitude of curve, as you can see, we have done a VBT procedure at 6 months, 12 months, 2 year, 3 year. You can see this spontaneous correction with growth. And then the patient comes with a in 5-year follow-up when the patient reached to maturity. Despite there is a breakage in the plastic or the cord, we have a satisfactory results, and this patient will the curve progression in this patient was successfully stopped. And this is a sagittal plane, and you can see the clinical improvement and also the appearance improvement in these slides. So how do we decide on which one we will do? Actually, it depends on the evidence-based medicine and doctor's experience and patient preferences and current status. Again, the template as we operate for those over 45 degrees or within a measurement error interval of 3 to 5 degrees. Why don't we operate 44 degree and then operate 46 degrees? So it's not really only curve magnitude dependent. We definitely talk with the patients and the parents and evaluate the current status of the patient, and then we give the decision according to all these three most important items. For example, this is a patient who had 82 degree of magnitude of curve. She is a professional gymnast and she wants to pursue with her career in gymnastics at the Olympic level. So although this is a little bit out of indication of vertebral body tethering, we discussed with the patients and the patient and the parents, and then we decided to do a VBT for this patient as the patient was hypermobile and the curve was very flexible. And actually this resulted with a successful result at the end of the 4 years. And then she turned back to gymnastics very early after the surgery, only 3 months after. And this is another patient, 90 to 61 degrees. Well, this is not convenient for non-fusion surgery, but we talk with the patient, and this is a new technique that we are doing. So we did a hybrid solution for this patient, fusing this thoracic spine, which is less mobile, but only doing a VBT at the lumbar spine. So scoliosis surgery today is a safe procedure with the advancements in the technology and high-skilled surgical teams with effective outcomes, really very high success rates and long-term stability. And there is a quick recovery with shorter hospital stays, rapid return to daily activities. And there is today more patient support with personalized care plans and ongoing support from medical professionals and the societies. So my final message to you is not to be afraid of your surgery, and don't forget scars aren't an imperfection. They're a representation of your ability to overcome anything that stands in your way. So scoliosis surgery, rarely necessary, fusion gold standard. VBT is a promising non-fusion surgical alternative, but optimum surgical alternative should be decided with a shared decision-making between the professionals and the families. Early diagnosis is very important because of the increases in success of conservative management and doing less invasive surgical solutions. So awareness and education is mandatory. Please help to increase awareness, increasing the chance of early diagnosis and easier management. And finally, happy Scoliosis Awareness Month.
Thank you, Ahmed, for this very interesting talk and showing up the very different options we have today for scoliosis treatment. And I really want to highlight once more that it's important to have the diagnosis early to really give patients a lot of different options and give them the best treatment individually. So our next talk will be by Javier, who will talk a bit about the long-term outcome which you can expect after surgery. That's also a very important aspect for our patients.
Thank you, Peter. So hi, everyone. My name is Javier Pizones, and I work in Madrid, Spain, in a big hospital. We do both pediatric and adult deformity surgery mainly. And within this, 3 or 4 years ago, we planned this research that we are ongoing right now, is what happens with patients that got operated when they were adolescents and now they are 50 or 55 years old. How was their life in these 30 years? So we started to plan this. The idea was to get patients that were treated conservatively at the beginning with braces, then surgically treated at the age of 14 or 15, and then see what happened 30 years after that when they're 50 years old. Was the life that we're leading. So we received a grant from the Scoliosis Research Society. This is going to take us 3 years. We are already 2.5 years on the road, so we still have 6 months more to go. And we named this project History because the H is from health. What is the health of these patients? IS is idiopathic scoliosis, and the T is for treatment. So we wanted to know the story and the history of these patients that were operated in the 80s. We have done a consortium between 13 different centers, and almost all the world is involved, 9 countries and 3 continents. And we are leading this from the ESSG, which is the European Spine Study Group that has been doing research together for the last 10 years. So our first thing that we wanted to do is this one. And this is my mentor, Dr. Pérez Grueso, who operated these patients in the 80s with the CD instrumentation. Some Harringtons were there too, but CD, that were instrumentations using hooks more than screws. And reunites with his patients 30 years after that and see how they were doing. So for that, he called individually his patients and invited them to undertake an interview with him, a 60-minute interview. Early before, we grouped together and decided what topics we wanted to touch on, and we will see that right here. So we wanted to touch on the adolescent period. How was the surgery? How was the initial conservative treatment, and what was the experience of surgery? And then in adulthood, how was the adjustment to the social environment, their current physical activity, the back health, the current health conditions, and how was overall satisfaction with all these 30 years that have gone by. And through the interviews, we saw there were also sub-themes or subtopics that everyone was touching while we were interviewing these patients. It was a 60-minute interview face-to-face. And then we gave questionnaires to patients. We did x-rays and we took MRIs to see if there was a difference in this, if something had happened in these last 30 years. So we started recruiting patients in my hospital, 284, and 100 were contacted. 3 refused participation and another 100 were interviewed. So again, this is the first part of the big research the topic that we will cover. I think by the end of this year, we will have 800 patients, 400 treated conservatively and 400 treated surgically. This talk that I'm giving today will cover only the first 100 that we interviewed. Mean age of our population was 47, so nearly 50, and mean follow-up 30 years since surgery. So the first theme that we touch is on conservative treatment to see how these patients reacted and had the reminiscence of what happened with conservative treatment. They really complained. So you guys really complained of the intensity of the brace, the casts. At that time, we did electrostimulation and night traction. I don't know if any who's listening went through this night traction, that you were hanging from your chin and your hips at night, and you had to have that traction. And some told us that they cheated some nights, releasing the traction when the mother was not watching because it was terrific. Thank God we don't do this anymore. We don't cast anymore adolescents, but we're still doing braces, and it's hard to wear those braces, and we know that. But although we know it's hard, this plus physical activity may give you a big chance of not to get into surgery. So if you wear your brace, the number of hours that your specialist is giving you, usually 17, 18 hours a day, you have a 72% chance not over going through surgery when you grow up. Whether if you don't wear it, you only have 48%. of chances of not going through surgery. So the second question was, how do you remember surgery and hospital admission? And most of you had very positive memories, and actually better memories of surgery than of your period of conservative treatment. And that was something striking for us. And the worst experiences were related to very complicated surgeries with double approach. Those were when we went anterior through the thorax and posterior through the spine. You don't have a good experience when you go to the resuscitation room, and we know that the first 2 or 3 years are not very easy for you to, days are not very easy for you to go through. Or if you had a complication, then memories were worst. But usually it's positive memories. And some of the patients told that they vividly remember the wake-up test. This is one thing we used to do in the 90s and early 2000s. We're not doing that in surgery anymore. It was to wake up the patient to see if the legs were moving. We don't do that anymore, just in specific cases, because we have a neurologist with us looking at your spinal cord during surgery. We also ask them about social life and work, and we saw that 32 from these 100, so 32% pursued higher education. They went to university. And here I give you the mean of the rate of the normal population in Spain going to university is 26%, so more or less the same as normal, or even a little bit higher. Most had administrative positions. 8 of them were housewives. Some patients reported limitations with load-bearing jobs. So you have to, do big jobs of physical lifting weights. Some had some back pain, and 8 received physical disability benefits. When we asked our 100 patients about the personal relationships and family and pregnancies, we saw that 1/3 were single. 57 out of 91 women had children, had offspring. This is a 62% rate, which in Spain, the mean of the normal population is 64%, so very similar. 1/3 of them did not want to have kids. Some of them were really afraid to transmit scoliosis to their kids, and this was really impactful for us. But some they didn't do it voluntarily, or they hadn't been able. And then 15 received successful epidural anesthesia. So even though almost all these patients were fused to L4, which is very low, the anesthetist can do epidural anesthesia during the childbirth. 30 of them did not receive it voluntarily. They didn't want to, or because it was failed attempt from the anesthetist, or secondarily to doctor's decision, they decided to go directly to cesarean section. But you see there was only 7% of cesarean sections, while the rate in Spain is 25%. So you don't have to be really concerned about that topic. So you don't have more cesarean sections that the normal population do. Again, physical activity, and these are patients' mean age, remember, is 47. 50% were really active or very active physically. The mean rate in Spain is 61%, so it's nearly very, very fair for you guys. 43% are engaged in continuous physical exercise, as Nikos told us, Pilates, skiing, soccer, boxing, some doing boxing and horseback riding. So we don't limit any kind of sports after surgery either, but some felt limitations. So we had patients telling us I really feel physically very restricted. But on the other hand, we had the other end with a lady that told us, I go up with my friends, sometimes biking in a route of 1,000 kilometers. So actually, if you force yourself to do sports, there's no limit on that. This is the main issue of you guys after surgery is back health. So 72% of you said disclosed lumbar pain, whereas the rate in Spain at that age, 50 years old, is 20%. So you're in a higher rate of having back pain, frequent and constant in 41 patients, and moderate and severe in 25%, so 1/4. Many of them were undergoing treatment, usually it's painkillers or physiotherapist, and only 7% of this population had to be extended, so had to be operated again because of residual discs were degenerated. Regarding self-image and appearance, most had dissatisfaction with the scar. Ahmed just talked that the scar is one of your signs that you're struggling through life, but you have the scar there, not only in cutaneous scar, not only in your skin, but also in in your mind, because you are someone that has scoliosis and ever had scoliosis. So you cannot compare to a peer, to a friend of you that has no scoliosis. And 52 complain about these things. So residual hump even after surgery, or a flat thoracic spine. Some of you had some prominent implants that you can touch through your skin. And then with time, you develop, not all of you, only 10%, but you develop some kind of anterior unbalance or coronal unbalance, which you are leaning to one side or to the front. Actually, when you're beginning to unbalance to the front, is because you're starting with your back pain, more severe back pain. And the other thing is back stiffness. These patients were all fused. Remember that in the 80s and 90s, all was fusion. So 70% perceived back stiffness. And as you see in the picture, and we say this before surgery, you are going to be able to bend over and touch your feet, but you're not going to be able to do a back round. So your back is always going to be stiff. About health conditions, people were doing well. So we had 3 breast cancers, only 3 patients out of 100 with a cancer, while in Spain, the rate at that age is 4% of cancers. 9 were depressed, but the rate of depression is 58% in a normal population. So I think you guys are tougher than normal population in the state of mind. And 4 had pulmonary pathology that were under treatment. And some of the patients that we interviewed were really concerned about the X-rays exposure, and we know that for adolescents is always a concern in the parents. If this can relate to tumors at the older ages, there's some is debatable. We have some papers talking about an increase in tumors, but at least in our population, the tumor rate was even a little bit lower than normal population. Most were satisfied with the treatment received. However, they felt that they had a stigma due to the experience of scoliosis, and they're really satisfied about having an interview again 30 years after with their same surgeon, the surgeon that operated on them. Parents were very keen, and mothers were keen to see again the surgeon. And very quick, this is the second step because these patients were interviewed, and this is a psychological point of view, what I've mentioned. We also had some questionnaires that we delivered. We gave patients these, maybe some of you have gone through all of these questionnaires that we bring you, but this is objectively, and comparing to the normal population, what our patients said, it was very positive. So almost 60% are doing normal life, like a normal here that does not have scoliosis. So PAS, which is acceptable status, is positive in 60% of you guys. So family-wise, active sports-wise, a relationship, social relationship, emotions, mental health, and general health is very, very similar to the norms. A little bit slightly underneath, but very similar to the norms. The only 2 things that are really a concern is back pain, as we mentioned. So for the normal people, for the normal population, 82% have no pain at 50 years old, whereas our population, only 26% had no pain. But only 9% had significant pain that had to be treated. So only 1 out of 10 are going to have back pain at the age of 50. The same thing as disability. So this is how you function with daily activities. Most of them were under the degree ODI 20, which means you're doing a normal life, and only 16% really have limitations in their normal duties or activities. So in conclusion, factors such as dissatisfaction with your self-image, you always have that, low back pain, which is higher than in the normal population, spine stiffness, you have been operated and fused. These were relevant to patients. But despite this, the great majority were satisfied with the treatment received and allowed them to lead an integrated life in society. So thank you all for listening.
So thank you, Javier, for giving this good talk and showing these promising results long-term after surgery. I will just put some questions which I receive often in my clinic also. And I still invite you, also the participants, to submit questions. So how do you think the treatments we have today, the new treatments, will affect the outcomes we will receive of the patients we treat surgically today in 30 years? Do you think...
Is this for me, Peter?
Yeah, Javier,
okay.
Please.
We don't know if surgeries we're doing today are going to lead to something different in the future. I think fusion is fusion, even though you use hooks or screws, it might be very, very similar. There's some promising future for you guys with VBT, with fusion-less surgery, but still, as Ahmed says, we only have 10 years of experience, so we don't know what is going to happen in the future. But we are really happy. We are happy, and patients are, most of them, happy of undergoing surgery. The next step is in our research, which is going to be really, really important, is to see the patient at the age of 15 with the same curve. Half of them will be operated, and the other half will be treated conservatively, not operated. And we want to see, and this will come in the near future, how are these patients comparable? So should we operate on the patients when they're 15 or not? This is the question that we have to unravel in the near future.
Thank you. We have one question from the audience. Javier, you have shown that there's some increased rate of back pain surgically treated patients, and the audience is asking for the conservative treatment. Maybe, Nikos, you can answer this. What is the role of conservative treatment approaches after surgery for curve maintenance and also maybe for the rate of back pain?
Yeah, I think this question is mostly related to my topic. At the moment, unfortunately, we don't have good evidence to show in terms of results that what we can do. So we still have a lot of work to do on that. And I think for this reason, we need a very good cooperation between the therapeutic team members, so the orthotist, the physiotherapist, and the orthopedic surgeon. From what I presented in my lecture, of course, there are many cases that they can get benefits from conservative approaches after spinal fusion or after non-fusion techniques, or a combination of them, like the hybrid option. And I think this is going to be very interesting in the next few years. We, in our clinic, we collect our data, and hopefully we can publish something on that. And I think also Ahmed can have some experience on that with non-fusion and combining with non-operative approaches post-operative.
So being active is always important, even no matter if you have been treated conservatively or surgically. It's important to stay active, to participate in sports. We have seen that. Ahmed, patients are very often very afraid of fusion when they come to my clinic, and they say, I'm very afraid about the restrictions they will experience in daily activities. What's your experience? What restrictions patients really experience after fusion surgery?
Yeah, that is actually a big question. And after 25 years of experiences, I try to reach to a conclusion from the literature, but also from my experience. So, I think they have some restrictions, after fusion. So, especially when the fusion goes to lumbar spine and below L3. But how much this is really, affecting their lives, especially in terms of, daily activities, is a big question mark. It also depends on how flexible the patient is, because it may change from patient to patient. But I think, those with lower spine fusions, I think one of the best evidences we have now in our hands, as Javi has stated, is the back pain. And that fusion may be causing, adjacent segment diseases. But if you ask me, if we have enough evidence to say that, fusion really results with a lot of back pain plus restrictions, from a theoretical point of view, yes, but we don't have the evidence that really their quality of life is, affected. So I think the other study that Javi has mentioned, and where I'm also a part of the study, I think that will really guide us or give more information about the longer term effects of fusion.
Thank you. Javier, another question I'm asked very often, and we also have talked about work patients are doing after scoliosis surgery. Are there specific jobs you would recommend a patient having been treated surgically for scoliosis that he should not do? Are there some restrictions?
No, we don't restrict anyone. They can do normal life. We encourage them to do physical activity, usually aerobic exercise. But if you want to go horseback riding, which is a big question always, we let them free to do whatever they want. But actually, we encourage them to do at least 2 times a week sports all through the life, because this is going to maintain a little bit the health of your mobile discs in the future.
Thanks. There's a more specific question of one patient. I'm sorry, we can't really answer your individual treatment questions, but maybe generally, we are treating scoliosis patients surgically already during adolescence in most cases. Why is it important to treat patients in adolescence, and what are the treatment options in early adults, in young adults, or in adult patients? Maybe Ahmed, you can think to that.
So the question is, what are the options for young adults?
Yeah.
Well, so as a person who really try to avoid fusion, first with very aggressive conservative treatment, and then, if possible, to do vertebral body tethering or non-fusion scoliosis solutions. It's a big challenge, especially for the young adults up to, I would say, 40 years of age. They usually have scoliosis borderline or had a conservative treatment and not operated, but with the progression going on in the adult ages. So I think our philosophy is the same. I started to do some hybrid operations for them, especially if the curve is at the lumbar spine, and if I have to fuse to up to L4. Then for the thoracic curve, I do fusion, and for the lumbar spine, I still do vertebral body tethering. But vertebral body tethering, the aim is actually to control the curve or to harness the growth in the growing spine. Here in those patients, it's used only for keeping the lumbar curve and at least to delay the progression and give the patient to be more mobile at his very active ages, up to 60s. So principles are similar, but there might be some little nuances, and there might be some longer fusions as they may develop some degeneration at the lumbar spine, especially close to the ages, 40s. So that's the main disadvantage.
There's been a question on the diagnostic measurements and the importance of X-rays during follow-up visits. Javier, can you maybe say how?
I was answering that one. We actually are doing another research on photos and on photographs and trying to see the progression of scoliosis only with photographs. We have also used, as the patient mentioned, scans, 3D scans, not radiating scans. But right now it's not the gold standard. And that appearance is very different than X-ray. So you can have a very high COP magnitude and very good appearance and the other way around. So yes, it's going to be a tool that maybe in the future is going to help us skip some X-rays. But up to now, I will have to say that X-rays is the gold standard. And at least we do it every 6 months when the patient is growing. But at least you need to have an image at least once a year.
Thank you.
Peter, if I can add something on that, I definitely agree with Javier. I think that because we also use as specialists for exercises, we use a lot of ways to monitor the patient before having the new X-ray. So we can have, let's say, a prediction in some way, but the clinical decision should be made under having an X-ray. You need to get more information. So that's true.
Thank you. So as we are running shortly out of time, one more last question. Maybe Ahmed, you can answer that. How does the age of that the diagnosis influences the risk of progression and the treatment options available. So if you diagnose scoliosis earlier in adolescence or in childhood.
Well, this is a great question. Actually, early diagnosis nowadays is very important because, maybe 10, 50 years ago, we were not really that good in conservative management, with the braces that we were using and also with our understanding of the deformity and the physical therapy. But now, early diagnosis may help progression of the scoliosis with the conservative management. I'm a strong believer on that. And also now we have those non-fusion technologies and the VBT, especially vertebral body tethering. I think also in my practice, most effective, especially on those patients when the disease is diagnosed, when the curve is between 40 to 60 degrees, and when the patient is really immature, maybe slightly pre-menarche status or just after the menarche status. So most of those patients are really benefiting a non-fusion surgery, preserving their motion and also enabling them to continue their growth. So in that case, in most countries, the school screening has been, quitted because they think that the conservative management was not really effective. But I certainly believe that, school screening should start, because early diagnosis really make the treatment more easier, and more efficient.
Thank you, Ahmed. So I think that's really the very important message we want to give to all of you during also Scoliosis Awareness Month, that early diagnosis really matters and can influence your treatment options and outcomes overall. So I think we come to an end. I thank you all for participating. Thanks to our speakers for these great and very interesting talks. And I would like to remind all participants that we have a recording of the webinar available on our webpage and on our YouTube channel. It will be probably available from next week on. So if you have not been with us from the beginning on, or if you have friends or colleagues who are interested in this topic, please let them know that they will find the webinar on our webpage, EUROSPINE.org. Thank you all for being with us today.